whatever you feel.
There you go. Yeah. No, what I do is everyone look at them and shame them. Everybody at the same time.
I think they should have to sing karaoke or something.
Something, yeah. I do shaming in my class because I've got a couple of people that won't turn their damn phones off, and so I just tell everyone to look at them and shame them. All right, how's everyone doing tonight? Okay, good. I'm kind of tired, so I'll get some motivation here. No, I'm doing all right. I think I actually know a couple of you guys, a few of you guys, so that's cool. For those of you that don't know me, my name's Chris. I teach over at Doñana Community College, and Laura May contacted me about having me come in and talk to you guys. I believe I'm talking a little bit about diabetic emergencies tonight. Was kind of the thesis, so that's more or less what we'll talk about a little bit. Just a little bit about my background. I got started in the military back in the mid-90s. I joined as a medic, and at that time I was able to take the national registry for EMT Basic before all the national stuff changed. And I worked as an EMT for a while and decided that I wanted to be a paramedic really bad. Unfortunately, where I lived at the time, the state that I was in, there wasn't a paramedic program in the entire state. None whatsoever. The state that I lived in was kind of similar to New Mexico in a way. It was Wyoming.
I was going to say it had to have been Montana or
Wyoming, and at that time there were less than 500,000 people in the entire state. There were more people in Alaska than Wyoming, so it was really rural. So guess what? There were no paramedic programs. What was I going to do? Well, I did the next worst thing, really, is what I did. I went to nursing school. So I graduated nursing school, and this was back in the early 2000s, and I said, you know what? I want to go to the first ER that hires me because I don't want to do anything but ER. Now, back then, the economy was just a little better than it is now, and you could actually, as a new graduate, get into the ER. So I put in apps, and I went to the very first hospital that hired me, and that happened to be Membres Memorial in Deming, New Mexico. So moved down to New Mexico and worked there for about 5 years or so. Then I ended up getting a job with, at the time, as you guys, those of you that have been with this, been doing EMS for a while, you've had to go along with the ride. But at the time, it was Southwest Medevac. So I was flying with Southwest Medevac, and then we got bought out by Omniflight, right? And then let's see, not PHI, but Native Air came in and bought Omniflight out, and Native Air was owned by they're owned by somebody else, whoever owns them, some big company out of Colorado. I forget anyway, they have gone through many different name changes, and I believe that they're still Native Air now. I haven't worked with them for a while. I worked there for a few years, and then I ended up taking a job working as a contractor overseas, primarily in Afghanistan. I did remote medical work and did some medevacing out of mainly out of the Kabul area in Afghanistan, and went to Balad, Iraq, a couple times. That was about all my Iraq experience, and then I came back and decided, what am I going to do now? I went to respiratory school and was going to be work as a respiratory therapist for a while. And after I graduated, I ended up getting offered a position at the college. So here I am, and that's what I do. So I actually really enjoy what I do at the college. I love working with people. So hopefully I'll have some interesting stuff I can throw at you guys today. So as I understand, just so I can get an idea of where people at, for the most part, we're looking at intermediate EMT kind of level of care. I will be talking about a couple of things that maybe go a little beyond what maybe you've heard before in your classes. But really what I want to do is just kind of explain why some of these weird things happen in diabetic emergencies. Because there's some really interesting things that happen. So with that, I'll kind of just start talking, and I don't have PowerPoints or any of that kind of silliness. As some of you that are in my classes know, a lot of times I don't even use PowerPoints when I teach. I just go to the board and vomit a bunch of stuff out there. I think it's probably, at least it's a bit more amusing than what I call death by PowerPoint, where you click. Look at that. Hey, look at that. You know, I get pretty bored pretty quickly, I imagine. Some of you are probably the same way. If you love PowerPoints, okay. More power to you. Okay, so let's go ahead and just talk a little bit about diabetic emergencies and kind of look at the big picture. So diabetes it's a kind of a complex disorder, and it's a complex group of disorders. It's not just one simple disorder. It's a complex group of disorders that revolves around how the body uses sugar. That's kind of the starting point. So with that, why is sugar so important? What's the big idea with sugar? What's going on there? Like,
It gives your cells fuel.
yeah, so sugar is the basic fuel that our cells use. And our cells use sugar. They actually burn sugar. It is actually a form of burning that goes on in our bodies, believe it or not. It's a little slower and a little more drawn out than taking some sugar and setting it on fire and literally burning it. But it's the same kind of thing. It's what's called oxidation. It is oxidizing sugar. It just does it a little differently than combusting it and burning it. But we're still doing the same thing. We're extracting energy from that sugar. And I just want to talk about the basic machineries that the cell uses to do it. We're not going to go overboard. We're not going to do a bunch of crazy stuff. But we're going to talk about just some of the basic machinery involved. So if you can imagine that this is a cell here. Okay, this is the cell membrane. This is outside of the cell, and this is inside of the cell here. Okay, my art is not particularly good, so you're just going to have to cope with that the best you can.
You've never seen Jim draw your drawing.
Okay, good. All right. So the surface of the cells have these little protein channels on them, and we'll talk about why those are important. So what happens is I eat something, and those sugars get absorbed into my bloodstream through my intestines, and I have sugar, specifically the sugar that our body uses, the specific form is known as glucose. Glucose, or dextrose. Dextrose is just another name for glucose. And I'm just going to put the chemical formula up there. It's nothing you have to memorize or anything like that, but I'm going to do that because it'll become relevant here in just a few minutes. So glucose, the sugar that our body uses, has 6 carbons, so it's what we call C6. That's 6 carbon atoms in it. C6, H12, so there are 12 hydrogen atoms in there, and there are 6 oxygen atoms. So C6, H12O6, that's the sugar. Now, again, don't spend all day, all night trying to memorize that. I'm just going to throw that up there because it's really interesting what happens to these atoms, and ultimately that's how our cells make energy. So this sugar is floating around, and the cell needs to use that sugar. So the first thing that needs to happen is the sugar needs to get into the cell. Can the sugar molecule, with 6 carbons, 12 hydrogens, and 6 oxygens, it's a fairly big molecule, can it get through the cell membrane? No. It's too big. It's just too big for the most part. There's actually a really cool little thing around that there's one area of the body where that's actually not the case, and it'll make sense here in a few minutes. But for the most part, sugar can't get into the cells without what?
Insulin.
Yeah. So what happens is, for the sugar to get into the cell, the sugar has to go through a receptor, a channel, designed just for the sugar. And what happens is insulin is a hormone that the pancreas in our body secretes. It secretes that insulin. That insulin is able to kind of combine with the sugar. So it kind of attaches, And then the insulin helps that sugar get through, helps that glucose get through that protein channel and into the cell. You guys, have you, when you took your EMT class, do you remember the term diffusion? Does that, and what diffusion is, it is the movement of dissolved stuff, like sugars and salts and things like that. That stuff is what we call a solute. So when you dissolve like some sugar in your coffee, that sugar is technically a solute. It's dissolved in the coffee. And the coffee is the solvent. It's the liquid that the sugar is dissolved in. Well, the body's the same way. The sugar dissolved in our body is a solute, whereas the water in our body is the solvent. It's what dissolves the sugar. The sugar molecules, the solute molecules, have this tendency where if you have them concentrated in one area, like so, say I have a large concentration of sugar molecules in this area, those sugar molecules are going to want to move to areas where it's less concentrated. And that movement of those dissolved particles is known as diffusion. So what happens is you have more glucose in your blood than you do in your cells. So that glucose wants to diffuse into the cells, but it can't because it can't get through this membrane here. But if your body secretes insulin, the insulin helps the sugar diffuse into the cell. And when you have a helper like that, we call that facilitated diffusion. So the insulin facilitates the diffusion of the sugar into the cell. And if you guys have any confusion or questions, please just ask me and say, hey, what the heck are you saying? I don't understand. You know, smack me, throw something at me, whatever. That's all right. So is everybody okay? More or less here. Okay. So here's the cool thing. So the sugar comes into the cell, and as soon as the sugar gets into the cell, there is a chemical reaction that occurs right as soon as it gets in. And I'm just going to draw a little circle like this. And you can think of that circle as a circular chemical reaction. It just kind of occurs. And as sugar's going through, it goes through the cycle. And it just goes around and around, and it's kind of continuously working as long as sugar is coming in through the cell. Again, you don't spend time trying to memorize all these things. It's just to kind of help us understand diabetes a little better. The name of that first cycle is glycolysis. All right, it's just a big word, glycolysis. What happens in glycolysis is this sugar here is broken down. And we break that sugar down into another molecule called pyruvate. Okay. And then the pyruvate goes somewhere else, deeper within the cell. And let me ask you guys a question. Where is the major power plant of the cell? Where's all the energy in the cell produced?
Mitochondria.
Inside the mitochondria. Yeah, so you go deeper into the cell and you have these little kidney bean shaped things, what we call organelles. Think of them as organs, cell organs. We call them organelles. And that pyruvate goes into these mitochondria. All right, so the pyruvate goes into the mitochondria. And there are two cycles that happen inside of the mitochondria. The first cycle, and I'm just going to draw that kind of that circle there again. The first cycle is something called the Krebs cycle. Okay. And in the Krebs cycle, this pyruvate molecule is broken down. And basically what happens is, do you see how in the glucose we had all these hydrogens here? 12 hydrogens? That's the predominant atom. We still have most of these hydrogens here. So what we do is we start tearing, in the Krebs cycle, I start tearing hydrogens off of that pyruvate. I break it down, I start tearing hydrogens off. Does that kind of make sense? So I'm starting to tear those hydrogens off because the body's going to use those hydrogens here in just a minute. So as I start tearing those hydrogens off, what am I left with if I tear all the hydrogens off? What am I left with? I'm left with carbon and oxygen. And what happens is those carbon and oxygen atoms can combine, and somebody said it, And you're absolutely correct. The waste product that comes out of the Krebs cycle is carbon dioxide, CO2. So CO2 is produced as waste. As I break that pyruvate down and I start tearing those hydrogens, I'm left with carbons and oxygens. So that's where my CO2 comes from what we call cellular respiration. So then what happens is I have all of those hydrogens, and those hydrogens have to go somewhere. And where they go is they go into another cycle within the mitochondria. And that cycle is called electron transport chain, the ETC, I'll just say. It's the electron transport chain. Okay, it's just a big word, but all the hydrogens go over there. And something really cool happens. And unfortunately, I'm not going to be able to talk about all the specifics. But basically what happens if you imagine that I take this little area here and I enlarge it right here. So I'm going to just kind of zoom in to the mitochondria and blow this up here. What I have inside the mitochondria is I have a membrane, and then I have these proteins that go through the membrane, like so. All right. And what happens is those hydrogens get dumped off right here. I dump the hydrogens off on this side of the membrane here, and they start to pile up. So if I have a lot of hydrogen atoms here, where do you suppose they want to go? They want to get over here, right? They want to diffuse down to here. Well, what happens is these hydrogen atoms have electrons. Okay, electrons is just a tiny little subatomic particle that makes up atoms. It's one of the major particles. You have electrons, and then you have protons, and then neutrons, but they're not as relevant. So basically what you have within a hydrogen atom is you have a proton, and then you have an electron that's kind of attracted to that proton. What happens is the electron is taken away, and the electron, the energy that electron has, is used to power these little proteins. So the energy of the electron powers these proteins, and then I have these little hydrogen atoms all by themselves, but they don't have an electron, and when you take an electron away from a hydrogen atom, it becomes what's called a proton. That's all that's left. It's just a positively charged little proton all by itself. And those protons, so I'm just going to put H plus now, okay, those protons will move through this little channel here at the end. They'll move through this channel. And this channel is really cool. And what it is it's kind of like a turbine. It has little hands, if you want to imagine. It has little hands that come out. And maybe I'll draw those. It has little hands that come out like this. So it's kind of like a propeller at the end. And what is the fundamental molecule of energy? Does anyone know? The actual molecule of energy that the body uses? What's the name of the energy molecule?
Carbohydrate.
Well, sugar is a carbohydrate. Ryan.
The fundamental energy.
It's a molecule. It's what the cell uses. It's energy. It's the unit of energy.
ATP.
ATP. Yeah, ATP. Yeah, so ATP, that's what we're trying to make, adenosine triphosphate. Well, what happens is this channel has an ADP molecule with just two phosphates in here, in this hand, and then another phosphorus group here. And what happens is, as those hydrogen atoms flow through that channel, it literally turns like this. The force of those atoms moving through literally turns the channel around, and it's called proton motive force. As those protons move through, it spins around, and it's able to connect that phosphorus group to the ADP. And when it does that, when it turns around and connects, it turns ADP into ATP.
Where did the phosphorus come from?
The phosphorus came from some other chemical cycles going on in the body, and from the diet, foods. In some cases, our body can manufacture it. So there's a whole there are a whole bunch of like millions and millions of other things occurring at the same time that I'm kind of ignoring to simplify it a little bit.
The phosphorus also is in the mitochondria.
Yes, the phosphorus the phosphate groups are manufactured, and they're coming into the mitochondria as this cycle is working. So, and they actually are made in other processes, which I'm kind of neglecting just to kind of keep it a bit more simplified. But you're absolutely right. They do have to be created and brought into the cells and that. So as that thing is spinning around, it's combining the phosphorus to the ADP and making ATP. So most of the energy of the cell is made right here. Most of the energy is made here. Only a very tiny amount of energy comes from like these two cycles here. Most of the energy comes from here. But here's the problem. Now I have all these hydrogens and these electrons. Okay, these protons and these electrons, I need to get rid of them. These are like waste building up. And the cool thing that the cell does to get rid of them is, what do you think it does?
Mixed with oxygen and water.
There you go. There you go. You're absolutely correct. This is why we need oxygen. I don't know if anyone's ever thought about this, but oxygen is nothing more than a garbage truck. That's why you need oxygen. It's a garbage truck for your cells. It literally gets rid of the garbage. So oxygen comes in, it combines with the hydrogen to make H2O, or water molecules. The hydrogen and the electrons to make water molecules. And you take that stuff away, and you make sure that there's more here than here, so that stuff keeps flowing through there. So this is the bigger picture of what's going on with glucose. Does that make sense? Okay, hopefully I don't want to make it more complicated than it needs to be, but this is kind of the bigger picture of what's going on with our cells making that ATP. And this is where diabetes comes into play. So I'm just going to kind of erase this here, or I am going to erase it rather. And we're going to start talking about some of the diabetic emergencies that we can run into. But before we do that, let's talk about diabetes mellitus, or DM, because that's the type of diabetes that we'll be talking about. There are actually other forms like diabetes insipidus, which is a water problem, where you have a problem, you can't hold on to water very well. But the type of diabetes we're going to talk about is what some people call the sugar diabetes, which is diabetes mellitus. And there are two flavors of diabetes mellitus. And what are the two major flavors?
Type 1, Type 2.
Type 1 and 2. You guys got it. Type 1 and Type 2. So let's talk about these real quick, compare and contrast them. What is the difference between Type 1 and 2? What's the big difference?
Type 1 is
insulin dependent.
well, yeah, but it's child onset.
There you go. So the first big point is it is almost always child onset. And as somebody else mentioned, it is insulin dependent, or IDDM, insulin dependent diabetes mellitus.
Now that's always true, isn't it, for Type 1?
Pretty much always, yeah. It is almost always child, or it can be adolescent, and it is always insulin dependent. And we'll talk about why that is. We're not quite sure exactly what happens, but we have a pretty good idea of what causes this, and I'll talk about that. Type 2 is more your adult onset. And Type 2 may be, or generally it starts out, non-insulin dependent.
In IDDM.
Yeah. Now, we are seeing more and more kids developing Type 2 diabetes because we just have more butterballs running around. We have more obesity. I could say that because I'm overweight. I'm overweight myself, so I figure I can say that without too much pretentiousness, but I mean, it is what it is. We have childhood obesity is a much bigger problem now in the U.S. than it's ever been. So we are seeing more type 2 diabetes occurring in younger people. And we'll talk about how it occurs, what the general mechanisms are. Let's talk about type 1. Have you guys talked or ever heard what causes it? What happens there?
Basically, your pancreas isn't producing insulin, so you need
Yeah, but
supplemental.
As when you're born, really, or is it?
It's actually not when you're born.
Okay.
Yeah, most kids are born fine, and then something happens to that child while they're growing up. And what we think happens is we think that most of what goes into the type 1 is what's known as an autoimmune reaction. What we find when we look at kids that get type 1 is they will have some sort of cold or they'll get some viral illness. They'll recover from that illness, and then after they recover, they are back in the hospital weeks, months later with diabetes. And what we think is going on is, for whatever reason, for reasons that we don't understand very well at this point, but what we think is going on is as the body begins to fight that infection, that virus that the kid has, there's a mistake that happens, and the body thinks that the pancreas, specifically the islet cells within the pancreas, is a disease. It is a pathogen or an antigen. And so the body ends up attacking. So the pancreas is kind of like a collateral damage, if you will.
Let me ask you a question.
Uh-huh.
And maybe you said the virus. Now, is it always a virus that does it?
I don't know that it's always a virus. Yeah. It tends to be viral because viral illnesses are just so common.
Sure.
But I couldn't say with confidence that it would. And I can't say with the greatest degree of certainty that that is the only mechanism, but it looks like when we look at the research and we look at what happens to patients, we see pretty clear patterns. So there may be other things going on, absolutely, but this is just something that the evidence seems to be pointing more in that direction.
And you said it can be adolescent onset.
Yes.
But
yes.
Is it because children don't have a good immune system that's causing this in a way?
I don't really know. If I were to guess, and this would be more of a guess, I think you might be on the right track that the immune system is developing very differently in a child than an adult. There's lots of cell division that's occurring. The cells are dividing, and whenever you have lots of cells dividing and lots of things happening, there is a chance for that process to undergo problems. And anytime you have that, lots of rapid cell division, you're at higher risk for problems. Now, is that necessarily the case? I don't know, but it's at least a hypothesis we can consider. But that does seem to be the problem, is that there's some sort of autoimmune response. The body attacks itself, and it wipes out those islet cells. So the pancreas is incapable of producing insulin. However, in your type 2 diabetics, it's not an autoimmune problem. What happens in type 2 diabetics is something known as insulin resistance. Insulin resistance. What happens is these cells become resistant to insulin. What happens is you have in a lot of cases, dietary, and they're probably genetic. There's probably a genetic component there as well, although I'm not sure how confident I am in saying that. But your cells get used to high levels of insulin in the body. Okay, and people like me that have more weight than we should, and we eat more sugars and carbs than we should, our pancreas is pumping out more insulin, and our cells kind of get used to all that insulin being around, and so the cells become resistant to insulin. which means that the pancreas has to make more insulin to get that sugar into the cells. And at some point, the cells may become so resistant that the pancreas is just not able to keep up. The pancreas is like, I can't keep up with the requirements of the cells. So what we see in patients with type 2 diabetes is sometimes if you can get on a diet and you can make lifestyle changes, you can lose weight, what will happen is their sugars will decrease, their cells will become less resistant, and they may not even need medications for their diabetes. If they make, now not everybody, but some people, they make lifestyle changes, they can really decrease how aggressive this is.
So can you stop being a diabetic once you are being a diabetic if you take care of it right or not?
I think there's a good argument that some people very well could no longer be diabetics. I think there's a very good argument that some people, if they're very aggressive, they make really aggressive lifestyle choices, they may very well not need any medications or any insulin or anything like that. So yeah, they're in a practical sense. Now, as far as like the official diagnosis, I'm not as confident there, but in a practical sense, yeah, there is a good chance. Some people not so much. There's a lot of variability there. But with type 2 diabetics, their pancreas can make insulin. That's kind of a take-home point there, is that their pancreas is still capable of producing some amount of insulin. It's just their cells are really resistant. So when we talk about treating patients with type 1, how do we treat them?
With insulin.
Yeah, they need insulin. I mean, there's just no way around that. They need insulin. Type 2 diabetics, though, there's more variability. Some type 2 diabetics, we may be able to treat them effectively with diet and exercise and good food, and that may be all they need, just lifestyle changes. Sometimes we can give them oral medications, PO meds. And are these medications insulin that we give them?
No.
What do they are? What do they do? What do these oral diabetic meds do?
Sugar-based, aren't they?
No.
Do they increase the cell's sensitivity?
No. What they do for the most part is they tell the pancreas to make more insulin. They're like, come on, pancreas, squeeze that insulin out. So oftentimes we'll find that people will go on oral meds, and at some point their pancreas is like, I can't do it. It doesn't matter how much metformin you give me, I can't do it. And then what do we have to do?
Give them some insulin.
We have to maybe. Yeah. We may have to give them insulin. There are many other options, though. They may we have longer acting insulins. We have long acting, short acting, intermediate acting, and so on and so forth. I'm not going to talk about all the different types of insulin, but there are many ways that we can combat this depending on the patient. Okay, so is everybody okay with kind of the different forms of diabetes, the different flavors, if you will? Everybody's okay? Awesome. All right. So let's talk about the major problems. There are really two major problems that we run into with diabetes. We run into problems where the blood sugar is too high. Okay, so my VGL, either my VGL is too high or my VGL is too low. I mean, those are really the two fundamental problems that we run into. As far as EMS, I would venture to say what we probably would prefer to run into would be hypoglycemia.
Well,
emergencies. Thinking emergency. Yeah, thinking
okay,
emergency.
That is a life-threatening
Yeah.
emergency.
Think of a.
It's a quick fix.
Yeah, it's a quick fix. So we can do something about it. A hyperglycemic, not necessarily somebody who's like say 200. Because what are you going to do for that? Nothing. That's 200. It's elevated, but it's not. But like life-threatening elevation, we'll say. I'll put that little caveat in there. We can actually do something about hypoglycemia, right? We can give glucose. Okay, we can give it orally. We can give it intravenously, depending on where you're at and in your ability, where you're at as far as your licensure goes. So that's fairly straightforward. But when we get into these emergencies where you have an elevated blood sugar, there's some problems that we can run into, and our ability to treat it is somewhat limited. But I will tell you guys that there are some things that you can do that are critically helpful, more important than you could ever imagine. So there are actually very important things we can do, and we'll talk about them here in just a few minutes. Okay, so everybody's more or less okay with that? Probably just a bunch of review, I bet, for the most part. And like, oh, he hasn't really talked about anything I haven't already heard. And I guess that's a good thing if that's the case, since you guys are right on this. Okay, so what I want to do now is, hypoglycemia is pretty straightforward. There's not a whole lot for me to say there that you guys probably haven't already heard about hypoglycemia. You guys know how to give dextrose, be it the Instaglucose, the tablets, or the gel, whatever you guys may carry. And those of you guys that are intermediates, what can I tell you about giving dextrose IV that you don't already know? You know that you have to have a large vein. You have to have a good IV. You know if that stuff infiltrates, there's a problem. Necrosis can be a really big problem. So you want to have a solid IV before you start giving that. Those of you guys that give it orally, you probably know, hey, if your patient's mental status is altered, giving it orally is probably not a good option. And why is that? Yeah, the swallowing. And what happens with the alteration in swallowing? What's the big concern? Aspirating that stuff. Yeah, you don't want to aspirate a bunch of dextrose into your lungs. It doesn't really do much for your lungs. Yeah, so you guys know that stuff. There's really not a whole lot else I can tell you. Huh?
Or for your diabetes.
No, it doesn't help anything. Yeah, it's just not good. It's just not good all around. So what I want to do is I want to spend more time talking about the elevated problems. And there's some really cool stuff that's going on. Not necessarily cool for your patient, but it's kind of cool to think about conceptually. So the two hyperglycemic emergencies that we run into are DKA, diabetic ketoacidosis. That's one. And then there's also something called HHS. And that may be something that you may be less familiar with. It's not nearly as common as DKA. But we'll just talk about it anyway. It has a couple of different names. HHS is a name that is kind of the name of the month. And that stands for hyperglycemic hyperosmolar syndrome. You may see the term hyperglycemic non-ketotic coma, or HINC. That's another way that it may be abbreviated as well. And we'll talk about kind of the difference between these two guys here. So we have diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome, or hyperglycemic non-ketotic coma. Boy, the words are just spilling out, aren't they? So basically what you have is you have ketoacidosis here, you don't have acidosis here. Okay, that's the major thing that's going on. In both cases, the blood glucose is really elevated. It's markedly elevated. But in this case, I'm not making ketones, and we'll talk about what's going on there. And in this case you are making ketones, excuse me. In this case, you're not. So let's go ahead and let's talk about DKA first. Because if we can understand DKA, then we'll have a little better understanding of HHS. So I'll zoom in on DKA real quick. So diabetic ketoacidosis. What type of diabetic is typically going to have DKA? One or two? What do you guys think? It's actually type 1. Yeah. It's almost exclusively type 1 diabetics. And I'm going to talk about why that is. your type 1 diabetics. Why type 1 diabetics almost always are the ones that go into DKA. In fact, most newly diagnosed type 1 diabetics, how do you think we diagnose them? They present in DKA. You go to their house or their parents take them into the hospital like, I don't know, he's thirsty and he's not acting right, he's having abdominal pain and he's just really sick and he has diabetes. What? And they're in DKA. So let's talk about a little bit about what happens in DKA. So in DKA, your pancreas takes a hit. Everybody's okay there. So what are you not making? You are not making any insulin whatsoever. Okay, so that's the first thing. There is no insulin being produced. Everybody's okay there. However, is there glucose in your body? What do you guys think?
Sure.
There is. Okay, there's no insulin, but there is glucose. Okay, there's no insulin, but there is glucose. But can that glucose get into your cells? No. But there's an exception to that. There's one exception to that, which is an interesting one. The glucose can get in to neurons, to nerve cells, without insulin. They can pass through what's called the blood-brain barrier, and they can go in. And your nerve cells don't need insulin. Well, that's good, right? That's good, because if that wasn't the case, what would happen to your DKA patient? If they couldn't get any glucose into their cells at all, what would happen to them?
Brain would die.
They'd be down, right? They'd be down and out. That would be all she wrote. So that's a good thing that we can at least get glucose into our neurons so our patients don't become unresponsive suddenly. Their brain's doing okay, but what about the rest of the cells in their body? The rest of the cells in their body start starving, and they're like, hey, what's going on? Come on, help me out here. They start starving. And when they start starving, they start releasing chemicals that tell the body, hey, body, we're dying. You better do something about this. And the body does do something about that. The body releases hormones, and these hormones cause triglycerides to break down. And we'll talk about why that is. So what happens in DKA is you make no insulin whatsoever. You're eating, you're drinking, okay, your glucose level is going what? Your glucose level is going up and up and up. The only place that glucose is going is into the brain. None of the other cells are using glucose at this point. Your glucose is going up and up and up and up. Your cells can't use it. Your cells start to starve, and they start telling the body, hey, help me out here. Your body then says, all right, let's break down some fat. Okay, some triglycerides. And let's talk about why that happens. Why do we need to break down fat? Well, you remember that picture I drew of the cell? I'm going to draw a smaller picture. So here you have the cell here, and I have the glucose entering the cell, and it goes through the glycolysis here, and then pyruvate pops out of glycolysis, and pyruvate goes into the mitochondria, and it goes through both the Krebs cycle and the electron transport. Well, here's the interesting thing, and I didn't tell you guys this earlier, but I'll tell it to you now. The first thing that happens to the pyruvate upon entering the Krebs cycle is that pyruvate is turned into another chemical known as acetyl coenzyme A, or acetyl-CoA. Everybody okay there? It's just a big word. Well, here's the interesting thing. When I break triglycerides down, a couple of things happens. Okay, so imagine that I'm breaking triglycerides down. One of a few things is created. The first thing that happens is I actually create acetyl-CoA when I break the fat down. And the acetyl-CoA can be fed directly into the Krebs cycle, and it can bypass all of this. It just bypasses all that, and it just goes right into the Krebs cycle, and then the cell can use that for energy. Does that kind of make sense there? So that's cool, right? Okay, the cells can make energy now. But here's the drawback. There are a couple of different waste products that are produced. Okay, a couple of different waste products. There is something called diacetic acid. And again, don't spend all night trying to acid. All right. Diacetic acid is also known as acetoacetic acid. Diacetic acid, whatever. And then there is another waste product known as beta-hydroxybutyric acid. Okay. Again, they're really long words, and it's not as important to memorize those names. So beta-hydroxybutyric acid. All right. Now, diacetic acid actually breaks down further, and it breaks down into something called acetone. And are you guys familiar with acetone? Right? It's nail polish remover. Yeah, acetone. So it breaks down to acetone. And these wastes, these beta-hydroxybutyric acid, acetone, this waste stuff here, they're really acidotic. First of all, they're acids. And they happen to be what are known as ketone bodies. They're called ketone bodies. They're ketone bodies, and they're acidic. All right? So in the process of making this acetyl-CoA and plugging into the cell, I'm making all this acidotic waste. These keto acids are building up. So, I'm going to erase this, and we're going to talk about the three big problems that happen with DKA. Okay, there are three big things that we run into with DKA. So DKA. So the first thing is metabolic acidosis. Our patient becomes acidotic. Why does our patient become acidotic? Because they break fats down. And in the process of breaking fats down, they make keto acids. Keto acid waste. Okay? Does that make sense?
What about the diacetic acid?
That breaks down into acetone, which is which is actually the actual ketone body, the more problematic one. So I'm becoming acidotic. My patient's becoming acidotic. Acid is building up in their blood. That's the first thing. The second thing that happens is something known as osmotic diuresis. Boy, that's a big word. Okay. So what is happening to your blood sugar in DKA?
Skyrocketing.
Just skyrocketing, right?
Yeah.
So what happens is, as my BGL goes up, at some point, normally sugar does not pass through the kidney. Normally sugar molecules do not go through the kidney. But at some point, once your sugar gets to about 250, right above that, sugar starts spilling into the kidney. It starts spilling into the urine because it's so high. And here's the interesting thing about sugar. As that sugar is spilling into your urine, that sugar actually pulls water with it. It's like, oh no, I'm not leaving without some water. So as your sugar gets high, it starts spilling into your kidneys, and that sugar starts stealing water from your body. That sugar causes osmosis, which is the movement of water, and diuresis just means you pee a lot. So the fact that your sugar is elevated actually causes you to lose water. So you become dehydrated. All right? Water gets pulled out of your body. You become, so now we're acidotic, we're dehydrated, and there's one other thing that happens. As we are getting acidotic, our body tries to get rid of acids. It really does. It tries to get rid of these acids. And the only way you can get rid of the acids happens to be through the kidney. But there's kind of a quid pro quo thing that happens in the kidneys. And what happens is, as the kidneys are getting rid of those acids take electrolytes out of the body. So you actually have the electrolyte imbalances. And what two electrolytes do you guys suppose are the ones that are that are actually leaving the body? Sodium and potassium. Yeah. So sodium and potassium. Ooh, here's a problem, particularly with potassium. What's potassium really important for?
Your heart.
Your heart, for your cardiac conduction, yeah. And sodium is really important for your brain, right? Sodium imbalances tend to affect the brain. Potassium imbalances tend to affect the heart. So now I'm potentially putting the heart and the brain at risk for problems. I'm dehydrating my body. And we're acidotic. So we've kind of got a triple punch, if you will. Boom, boom, boom. My body's taking 3 big hits. So when we look at our patients, they look terrible, right? They are in shock. They're dehydrated. They're profoundly dehydrated. So they look like someone's dehydrated. What's their heart rate? They're tachycardic. Okay, they're tachycardic. Their blood pressure may be low if they're profoundly dehydrated. Their mucous membranes are dry. Are they thirsty? Typically very thirsty. That's called polyphagia. They're thirsty. They're hungry. They're urinating a lot. They have polyuria. Polydipsia, which is being very thirsty. They may have. Will they have an increased respiratory rate?
Yeah.
Why? Why would their respiratory rate increase?
Get off the acids.
Yeah. The primary stimulus for your body to breathe is acid levels. That's actually, and I know probably some of you have heard that it's carbon dioxide. Have you guys been told that before? Oh, CO2 is your... No, it's not CO2. Not CO2 at all. It's actually acid levels in your brain. When your body becomes acidotic, acid levels or a decrease in your pH triggers chemoreceptors in your brain, and those chemoreceptors tell your lungs to breathe faster and deeper. But the reason that they say carbon dioxide is a stimulus to breathe is because carbon dioxide is turned into an acid in the body, actually. Carbon dioxide is turned into something called carbonic acid. So CO2 does not remain CO2 very long. It's turned into an acid. But it's actually acid levels that are our primary stimulus to breathe. So the acidosis creates what's known as Kussmaul's respirations. It's very rapid, deep respirations. Oftentimes the patients may have abdominal pain, and they may even be lethargic or have neurological problems as well if this gets really bad. Okay, and you guys have all seen this. You've seen these signs and symptoms. Nothing new here, nothing new there. So, with all of that in mind, what can we do? What can we do to help these patients out before they get to the hospital? Do you think fluids are going to be important? Mm-hmm. Yeah.
Flush some of the sugar out.
Diluted.
There you go. Yeah, there you go. Believe it or not, the single most important intervention that you guys can do, aside from making sure their airway is open and they're breathing and all that, but the single most important intervention that you guys can do is give these patients fluid. Give them fluids. Give them isotonic crystalloids, normal saline, lactated ringers. The fluid is going to do a couple of things. The fluid is going to begin to correct their dehydration. Okay, so it's going to fill that container back up. And the fluid is going to dilute that sugar out a little bit. And then once I start diluting that sugar, I am going to stop the osmotic diuresis, right? I'm going to, or slow this down so I'm not losing as much fluid, which means that I am going to slow down the loss of electrolytes. There's not much I can do about the acids, okay? Taking care of the acidosis will be something that occurs later at the hospital. But the first hour of treatment, and this is in the hospital too, believe it or not, if somebody came into the hospital, for the first hour, we would not do anything different than what you guys would do, believe it or not. Patients do not get insulin right away. And people are like, oh, give them insulin. No. You got to take care of the dehydration first. And you can actually see their blood sugars drop. Their blood sugars can drop fairly dramatically in that first hour as you hydrate them. And then once you get their fluid levels up and run some lab tests and actually see where they're at, then you can look at insulin and all the other stuff that happens later on down the line. So believe it or not, giving appropriate fluids is going to be so helpful for you guys. How much fluid are we going to give these patients? Well,
20 milliliters.
there you go, right? Run home to mom, right? And mom says, when it comes to giving fluid boluses, mom says 20 milliliters per kilogram. That is a reasonable starting point, and it works well for both kids and adults. So if you're a 70 kilogram adult, we'll say, what's 7 times 2?
14.
Which is going to be about 1.4 liters. That's a reasonable bolus. I would say what you could do, just give them a liter up front. Give an adult a liter up front. See how they do. Here in Las Cruces, at least, now once you're out in the county, it may take longer, but here in Las Cruces, you can get a liter in during a hospital transport. Out in the county, you may be able to get a little more than that, but I'd certainly give a 20 milliliter per kilogram bolus and then recheck them, check their vital signs and recheck their blood sugar and see how it is. Oftentimes, the glucometers that you guys carry, what are they going to do?
They'll just read high.
They're not going to give you sugar. They're going to read high. So you're not going to know exactly what their sugar. I think it's about 600, right? It's about, what, 500-600?
600.
Yeah, and they just read high. So that's going to be, a primary treatment for diabetic ketoacidosis. Okay, I've been yakking for an hour. Do you guys want to take a little break, stretch, relax, just for a few? Okay, yeah, go ahead. I've been yakking long enough.